imaging modalities. CT represents an anatomic imaging modality primarily, and in that situation, it offers one particular difference characteristically with functional imaging. To be able to detect coronary disease indirectly using functional imaging, we have to stress the patient, and second, we need to have a coronary stenosis of sufficient severity, proximal location in order to provoke ischemia. That typically sits in the range of 50 to 70% stenosis, and that's how typically functional imaging establishes the diagnosis of CAD. In contrast, CT represents the opportunity of visualizing coronary disease at an earlier stage, even before invasive coronary angiography, since it allows to visualize the vessel wall. Next, please. Since our initial study that we performed to validate CT coronary angiography in a double-blinded interpretation of CT versus invasive quantitative coronary angiography, we demonstrated that the most important value of CT, if you can click please one more time, is a negative predictive value. Once you have a CT coronary angiogram that demonstrates normal coronaries, the likelihood of obstructive coronary disease is practically zero. Next, please. More recently, a meta-analysis that took about 6,000 patients that have been enrolled in different multi-center trials confirm the same findings. If you can click one more time, please. The value of CT, next, is a negative predictive value. So if you have an individual with low or intermediate probability of CAD, the negative result will bring that probability to practically zero. Next. In the emergency room, CT represents an ideal modality. It only requires imaging once. It doesn't require the patient to be stressed for the procedure, provided the patient doesn't have some of the contraindications that I will discuss later on. CT can be done relatively quickly, and studies have demonstrated that you can discharge patients from the ED much sooner than when they're evaluated with a conventional approach that often involves functional imaging. Next. I do want to call to your attention that, however, that depends a lot on availability of the modality. This is our own experience where we use stress echo, myocardial perfusion imaging, and CT in the ED setting. And you can see that the patients that are eligible to undergo this modality varies. For stress echo, about 77%. For myocardial perfusion imaging, about 67%. And for CT, about 62% of all patients that present with chest pain syndrome are eligible for the modality. You can see that in our hands, actually, the utilization of CT is relatively low, with 27% of the cases that were eligible versus 76% for stress echo. And primarily, the reason is that our ER is very busy, and the CT is being utilized often to evaluate acute abdomen and other conditions that require use. Next, please. So in our hands, actually, stress echo is a faster modality to evaluate patients in the emergency room. Next slide, please. Nevertheless, keep in mind that CT has certain advantages that are important. And if you have the technology available, it does represent an advantage in the sense that only about 10% of patients that present with chest pain actually have an acute coronary syndrome. About 1.3% have acute coronary embolism. Several have other conditions like pneumonia, dissection. Next, please. And we're talking here about a patient with COVID-19. In the era of COVID-19, all imaging modalities are restricted because of the risk of contamination among patients. So radiology experts have published their guidelines in the sense of how many or when should be done imaging in this case scenarios. The same restriction will obviously apply to other imaging modalities. Next. So the problem with CT in this setting is what do we do when the probability of coronary disease is very high? Next, please. Next. And I think this is a question that remains, particularly this patient. This patient has many contraindications for CT. It has an elevated creatinine. This patient has obviously ST elevations, which are not typical of the population that have been studied. Typically, patient with a low TIMI score, and this patient is tachycardia, which is another contraindication. Next. The future of CT probably will have functional imaging tied to anatomic imaging. This is an example of CT using dual energy, where you can actually look at iodine maps and perfusion of the lung in a patient with pulmonary embolism at the same time that you detect the anatomic defect. And the final slide, please. And that could potentially be applied to evaluate myocardial perfusion at rest and with the stress. So in summary, with the final slide, CT is a technique that has a very high negative predictive value. It's a low risk, no stressor required. It evaluates other imaging threatening causes of chest pain. The efficiency of using CT depends on the availability and the local expertise. It has a low positive predictive value, however, in patients with non-coronary disease. And obviously, in this patient in particularly, is not the ideal modality, as I say, since the patient has acute renal failure, tachycardia, and an EKG that demonstrates a supurate syndrome. Thank you.
Okay. Thank you so much, Dr. Garcia. Now we'll be moving on to our audience discussion and panel. If you can refer to your polls, we're going to be activating them soon, or please submit a question. We're eager to hear from you.
Can you ask the question? Let's start the, all right, there's no questions, so okay, go to the
So if you go to your live poll that we're going to be activating now. So we're going to be going to our live poll. Our first question is, what is your imaging test of choice for first evaluation of chest pain in the ED? Is it A, echo, B, CT angiogram, C, invasive angiogram, D, stress nuclear, or E, stress echo?
¿Cuál, Miguel, Miguel Galicia? ¿Cuál de esos, cómo evaluarías tú al paciente?
A que del caso.
Sí, el del caso.
Si viene en un contexto de un síndrome coronario agudo, necesita coronariografía, pero no sé si se refieren a la evaluación inicial. O sea,
sí, evaluación inicial, técnicas de imagen, tienes ahí todas disponibles. Eco de reposo, eco estrés, tomografía, resonancia. Digo, tomografía o diciendo.
No, yo creo que la imagen inicial debe ser el eco bedside, que le llaman, o sea, hacer un eco lo antes posible para evaluar la función sistólica, las alteraciones de la movilidad y buscar de dónde viene ese soplo que se escucha.
Okay.
Como evaluación así, lo primero que se debe de hacer.
Perfecto. Vamos a ver qué respondieron ellos.
So we have people voting. That's great. Keep the votes coming. I don't know. We see it. You can see it.
Yeah, we see it. So I hope everybody can see the poll. So it seems like the vast majority feels that echocardiography is the first imaging modality. Dr. Garcia, since you gave us an excellent talk on CT in chest pain and dyspnea evaluation. What is your feeling about this?
So obviously, in this particular case, echocardiography is definitely the modality of choice. This is a patient who has clearly EKG characteristics of myocardial infarction and ST elevation myocardial infarction. You could argue that probably no imaging modality is the way to go. Will be an echo on the way to the cath lab to perform an invasive coronary angiogram. CT definitely would not be the modality in this case. However, in majority of cases, in a patient with normal electrocardiogram and with a one set of cardiac enzyme that is negative, echocardiography at rest would have a very low negative predictive value since it's not stressing the patient. And a stress echocardiography is a valuable modality. It can be employed. It doesn't have the same high sensitivity as CT, but in our experience, it's a reasonable alternative. I think either one of those is useful and definitely can be used to discharge the patient safely home.
Okay. Thank you. We have an audience question that is asking if POCUS is billable. Dr. Raza, could you enlighten us on this, please?
Yeah, it's a good question. I think it definitely depends on each individual institution. In some situations, it's billed as an adjunct to a more extended physical examination, particularly if it's being used for a very targeted indication or complaint or symptom. It does depend. And there are also some situations where institutions have got mechanisms to do a brief report, and then that can be limited. That can be billed as like a limited study. And in the emergency room, sometimes they bill those as like a limited ultrasound study. I would have to look up the diagnostic codes, but it definitely is possible. And then the other thing it can be that can be done is you can bill like an extended physical examination for that particular visit.
Okay, thank you. I think we will move on with the next part of our case presentation. Thanks, everybody.
Thank you to everyone so far. So I'm going to give a brief clinical update. So a POCUS was done in the emergency room for our patient. The left ventricular volume was normal. The function was borderline to mildly decreased, approximately 55 to 60%. Some notable findings included mild left ventricular hypertrophy and basal inferior wall hypokinesis. Later that day, a complete echocardiogram was performed. Similar findings were noted. Better appreciated is akinesia of the basal to mid inferior wall of the left ventricle and a large ventricular septal defect with left to right shunting across the muscular septum near the apex. Upon further interrogation, the defect was measured at approximately 1.7 centimeters with a peak pressure gradient of 38 millimeters of mercury. Our next speaker today will be Denise Ignatowski. She's going to be describing to us echo imaging in acute coronary syndrome from a sonographer perspective.
Thank you so much for ASC for inviting me to this. It's always an honor to be a representative of the sonographer point of view. So I'm Denise. I'm the sonographer and supervisor of the lab in Milwaukee, Wisconsin. And we are consistently training students and fellows and new sonographers in our lab. And as a large cardiac center, we are often sent to evaluate patients for acute chest pain. Next slide. So when going to the ED to evaluate a patient for chest pain, the parasternal images are really where we get to start piecing together our investigation. It really gives us the first glance of our overall function. Next slide, please. And we can also begin to rule out conditions like aortic dissection, as seen here with this nice type A, and as Dr. Raza had beautifully highlighted as well. This image, of course, is acquired by going an intercostal space up and lateral towards the left shoulder, and often with a breath out. Next slide. But a lot of times you are sent to the room just for function, right? Your function is the main event. Now, understanding true function is important for an echo, but it should be the platform of your investigation and not the only answer. Next slide. For example, for this patient, understanding their ischemic cardiomyopathy state led me to evaluate issues such as the severity and presence of ischemic MR. Next slide. Also, for those patients with severely reduced function, no matter how well you think you see the walls, even with contrast, next slide, a diligent sonographer will sweep through the planes to ensure no abnormality is missed, like in this case, a very sticky mural thrombus. Next slide. Many times we may see wall motion abnormalities like this and either consider Takotsubo or multi-vessel disease. But again, we want a thorough approach to care. Next slide. And knowing the apex is thinned and akinetic can make it vulnerable to mechanical issues such as VSDs. Next slide. This patient's apical wall ruptured at the apex, causing a large left to right shunt. Next slide. So the position of the wall motion abnormality when evaluating function is very important when understanding what mechanical issues may arise. For this patient, there was not a wall rupture, but instead a post-MI papillary muscle rupture producing severe acute MR. Next slide. Now, anyone who has been able to scan knows that all investigations during an echo are only as good as the technique. And it's always so important to remind sonographers that careful, diligent scanning can be crucial to a patient's care path. This example is actually the same heart during the same echo in the same time period. A high foreshortened window actually falsely shows wall motion abnormalities that with a lower, more accurate window shows are not there. Next slide. So with diligent echo, we don't have to stop just at function, but can accurately evaluate for complications such as dissection, thrombus, and ischemic MR, and mechanical issues such as papillary muscle rupture and VSD. Thank you so much.
So much, Denise Ignatowski. We really appreciated that. Next, we have Dr. Rigglein, who's going to be describing the use of echo imaging and CAD evaluation.
Thank you very much for the opportunity to speak with you and to comment on this case with examples using echocardiography. Next slide, please. So if we go back to the presentation of our patient, the combination of a lowish blood pressure, elevated heart rate, pulmonary congestion, and cool extremities suggests that he's in cardiogenic shock. Echo is the key imaging modality to identify the cause of the shock, which then, of course, will lead to the appropriate treatment. In a patient who presents with cardiogenic shock, the most common cause is extensive LV dysfunction. However, in a patient who presents late with a myocardial infarction, we always have to think of the mechanical complications. And Denise beautifully demonstrated a few of these, including acute severe MR, ventricular septal defect. We also have to think of subacute free wall rupture. Other non-cardiac causes include volume depletion, blood loss, and aortic dissection, which are all extremely important to identify. Next slide, please. So if we think about the mechanical complications of myocardial infarction, first we'll start with the ruptured papillary muscle, and you'll see the examples on the right-hand side of our screen. You see that usually on echo, the left ventricular systolic function is quite hyperdynamic. You see the disassociation of the papillary muscle from its head and is kind of flopping around, and you see the associated severe mitral regurgitation. On the zoomed up view, you can actually see almost like a jigsaw puzzle of the ruptured head of the papillary muscle and where it would have attached if it was still attached to the portion of the papillary muscle attached to the LV wall. Ruptured papillary muscles happen about 1% of the time. Most often it occurs in the posterior medial papillary muscle due to its usual single blood supply. It usually happens within 24 hours and 3 to 5 days with a range of 1 to 14 days after the incident MI. Clinically, patients present with shortness of breath and pulmonary edema, as well as hypotension. On physical exam, there's a soft murmur in many cases, even though the MR may be severe. There's no thrill. There can be variable signs of RV overload, severe pulmonary edema, and cardiogenic shock. If a right heart catheter was in place, there would be no step up in the oxygen saturation from the RA to the RV, although we would see large V waves and a high pulmonary capillary wedge pressure. Next slide, please. Here is a patient, a different patient that presented with a ruptured papillary muscle. She was quite obese, had COPD, and had very difficult images from a transthoracic standpoint, so it was very difficult to make the diagnosis. In such cases, transesophageal echo can be life-saving and clearly identify the diagnosis as it has in this particular case, where you can see the ruptured portion of the papillary muscle still attached to the posterior leaflet of the mitral valve, resulting in severe mitral regurgitation. Next slide, please. Now, ischemic mitral regurgitation is a less dramatic but still lethal complication of myocardial infarction, usually those that affect the infralateral wall. It can occur in up to 19% of patients after MI, and it is caused by restricted motion of the posterior leaflet due to papillary muscle displacement. It's an independent marker of long and short-term survival, and the regurgitant volume and effective regurgitant orifice area of the mitral valve are independent predictors of mortality. And you see an example on the right-hand side of the screen of a patient who has suffered a circumflex infarct, resulting in an infralateral wall motion abnormality, tethering of the mitral valve leaflets with a posteriorly directed jet of MR. If we go to the next slide, you'll see the same patient in the apical view, and you see the typical end-to-side coaptation of the mitral valve with that restricted posterior leaflet. And because of the restriction, the anterior leaflet closes behind the posterior leaflet, almost forming like a T. And that results in the posteriorly directed jet of MR. Next slide, please. Ventricular septal defect is what has caused our patient's cardiogenic shock. Here's another example on our right-hand side of the screen with a VSD very similar to what was found in our patient at the apical aspect of the interventricular septum. You see that color flow at the apex and the high velocity detected with spectral Doppler imaging. VSDs occur in about 1 to 3% of individuals with MI without reperfusion therapy, with a significantly decreased incidence in those who receive fibrinolytic therapy. Of the patients who present in shock, about 3.9% of them will have a VSD. It also has a bimodal time course similar to the ruptured papillary muscle. And clinically, patients present with chest pain, shortness of breath, and hypotension. On physical exam, there's a harsh holosystolic murmur with a thrill, an S3, an accentuated second heart sound, pulmonary edema, biventricular failure, and cardiogenic shock. On the right heart catheter, there is an increase in oxygen saturation between the RA and the RV and large V waves. Next slide, please. Here's a three-dimensional echo of the patient with the
1 minute, please.
apical septal VSD, and the 3D echo can be used to actually measure the size of the defect. Next slide, please. Left ventricular free wall rupture is another complication that can be found late in MI. This is a pathologic view of such a person who did not survive, which is often the case in these ruptured in the ruptured free wall. They occur in 0.8 to 6.2% of patients with MI, and fibrinolytic therapy does not seem to decrease the risk, although primary PTCA does. It also has a bimodal time course. Clinical findings include angina, pleuritic, or pericardial chest pain. because of associated pericardial fusions and sometimes tamponade. There can be syncope, hypotension, arrhythmia, nausea, restlessness, hypotension, and sudden death. On physical exam, 29% of patients present with JVD, 47% can present with pulsus paradox, and electromechanical dissociation and shock. Right heart cath can be very insensitive since the classic signs of tamponade may not always be present. Next slide. If a patient with a free wall rupture is lucky and the pericardium will contain the rupture, that is then what causes a pseudoaneurysm. On the left side of the screen is a patient who suffered an MI and had the contained rupture by the pericardium and was able to survive. 2 years later, however, there was significant expansion of the pseudoaneurysm, and it was actually pressing on her esophagus and causing dysphagia. And she was taken to the OR to remove the pseudoaneurysm and repair the LV. So this is just a breakdown of some of the complications that we can see in patients who present particularly late with a myocardial infarction and how echocardiography can help us identify the cause. Thank you.
Thank you so much, Dr. Rigglein. Next, we have Dr. Henry, who will be describing MRI and CT in the evaluation of late STEMI.
All right, thank you very much for the opportunity to present today. Next slide. So I like to think about these really in two different categories of patients. As a radiologist, we encounter these patients when they present with a complication. And oftentimes they get the CT before they've had echocardiography or other cardiac imaging. That's because they're presenting to the emergency department with acute symptoms. Now, it may be pericarditis, a Dressler syndrome. It may be something more sinister where they have hemodynamic instability, like a ventricular rupture, as has been discussed, or they may present with symptoms of stroke or emboli to their abdominal viscera or extremities from akinesis and thrombus formation. Next, please. Then there's the other category of patients. These tend to be more stable, and these are patients that have a recognized infarct and suspected complication. You want further evaluation. Often these patients will get MR rather than CT. We try to avoid sending unstable patients to an MRI scanner, but certainly if patients have some degree of failure and you're trying to just assess function, assess viability of the infarcted myocardium, if you're trying to evaluate an aneurysm or pseudoaneurysm, detect thrombus, or look for, quantify a shunt from, say, a ventricular septal defect and rupture, that may be a suitable indication for MRI. Next. So here's an example of a patient presenting acutely ill. And often these patients undergo pulmonary embolism protocol CTs, as that's kind of the default in the emergency department. Patient with a known recent myocardial infarction, they have hemopericardium. Whenever I see high density fluid like this, you can see most of it along the posterior wall of the left atrium. Now, this is one of the things that scares me more than anything as a cardiothoracic radiologist. Hemopericardium is usually a sign of something seriously wrong. And in this case, you can see on the right-hand image, there's thinning of the basal lateral wall, and it's slightly lower in attenuation. Put two and two together here, this is highly suggestive of myocardial rupture. This patient was rushed to the operating room, and this rupture was confirmed from a recent myocardial infarct. Next. So as was mentioned, ventricular rupture is something we see on occasion. It's often on CT when these patients present to the emergency department, usually within the first couple of weeks, and it often involves the lateral wall. Internal rupture may result in a ventricular septal defect, as has been discussed, and as I will show you another case of it. But here we look for hemopericardium, and really hemopericardium is either aortic or it's from myocardial rupture in most cases, such as this case. Next. This is another one very similar. And this is a finding that most general radiologists may not make confidently, but we see this on occasion and are pretty confident in the diagnosis. These are windowed harshly so you can see the edema within the wall of within the lateral wall, and really lack of perfusion from a recent infarct. On the left-hand image, there's slightly increased attenuation of the pericardial fluid. This is again a patient with hemopericardium, and that's a little bit of contrast that's actually leaking into the pericardium. So even though we don't see the rupture, we infer that it is likely there. This is another patient that was able to make it to surgery despite tamponade, survived with rupture repair of their ruptured free wall. Next. So ruptures can be external, as I've mentioned. Here's another patient. This is one with a more of an acute presentation of a pseudoaneurysm. It's still a kind of contained rupture, but they have a large volume of hemopericardium and were hemodynamically unstable. Next. Or you can have internal rupture. And this is a patient who has, as you can see on the inferior portion of the screen, an acquired ventricular septal defect. This was an inferior wall infarct. Really, the inferior ventricular septum is blown out, and there's contrast that's jetting across from left to right into the right ventricle, in addition to a moderate-sized pericardial effusion. Next. So MRI, we can use it for really three main functions in these cases. We can do cine imaging to evaluate the myocardial function or the left ventricular function. We can give contrast to assess tissue characteristics like viability, look for thrombus. And finally, we can do flow quantification, looking for shunts or confirming the presence or absence of a shunt. Next. Here's an example of a lateral wall infarct, and we can see not only akinesis, but dyskinesis as this wall bows outward during systole. On this delayed gadolinium enhancement on the right-hand side of the screen, the enhancing portion of the myocardium is a transmural infarct. That is non-viable myocardium. It's a full thickness infarct. And of course, this is someone that may be at risk for subsequent rupture. Next. This is another example of an infarct, in this case in the LAD territory on this 4-chamber cine. You see that there's akinesis of really the entire anterior and apical walls. On the right-hand image, there's delayed enhancement indicative of scar, again, a transmural infarct. And not only that, we get a good look at an enormous thrombus within this left ventricle. All of that signal void that you see both on the cine and the darker area on the post-contrast image is all thrombus. And this was a patient that actually presented with a stroke and with heart failure, as you can see from bilateral pleural effusions. Next. And finally, ventricular septal defects. Oftentimes these patients aren't stable enough or the diagnosis is known and they go to the emergency or to the operating room. These were two examples from colleagues of acquired ventricular septal defects, and you can see flow across these in turbulent flow, little flow jets into the right ventricle in each instance. Next slide. Occasionally, the diagnosis isn't that clear. This was a case of a possible small acquired ventricular septal defect. We can do flow imaging where we can quantify the flow across the aorta and the pulmonic valve in each heartbeat. And in this case, we calculated that it was 1-to-1. So reassuring finding that there's equal flow across both sides of the circulation and no shunt. Next slide. So thank you very much for this brief introduction to CT and MR and complications.
Thank you so much, Dr. Henry. We have a quick clinical update. Here's the transesophageal echo for our patient. It was performed the day after he presented. Again, we see the prominent muscular ventricular septal defect. It's appreciated near the apex with ongoing akinesis of the basal to mid-inferior wall, as well as the basal to mid-inferoseptal wall of the left ventricle. Again, we see the color flow prominently left to right. Finally, we have some CT images of that muscular ventricular septal defect. Next, we have Dr. Douglas, who's going to be discussing pros and cons of each of these imaging modalities that we've discussed.
Great, thank you. It's a pleasure to be here and have the opportunity to discuss such a rich case, both in terms of pathology and imaging findings. Next slide, please. I have relationships with a heart flow CT company. Next slide. So when we think about imaging pros and cons, it's often good to go back to first principles and think about what we are trying to accomplish with imaging because if we're not trying to accomplish it, it's hard to be a pro, of course. And the very first one that's very clear here is that the patient's needs always come first. So while it's wonderful to get pretty pictures and to have prolonged exams, for example, what the patient needs is comes first. And in this patient, as I'll talk about in a minute, the clinical situation was actually kind of dicey. And so it was important to be parsimonious about the imaging performed to make sure the patient could get to therapy. The other thing I would say about imaging, at times, the best test may be no test, or maybe no second test, if you will. Imaging is a diagnostic tool. Its purpose is to add information. If you already have the information you need, another test or any test may not be of great use. And specifically, when we think about imaging, it's not the information that we glean from it is what's most important. And in an emergency situation, in an acute situation, information is not really needed unless it can and will be acted upon. In other words, very pragmatic. It must change thinking, either our diagnosis or risk stratification, or change treatment to impact outcomes. Imaging alone cannot impact outcomes. And when we're thinking about that, it's often hard to add information or to change care without a specific imaging question. Look under the hood may be a reasonable approach to a patient in shock, but we're actually asking the question, is there or is there not LV dysfunction or acute MR or VSD or free wall rupture, such as what you've heard and seen in the prior talks. So in selecting a test, first formulate a question and then consider the pros and cons of obtaining the answer. Next slide, please. So to recap, this is a 52-year-old man with a delayed presentation of MI. His initial evaluation indicates shock, as has been summarized, with clear inferior ST elevation with evolving cues and pulmonary edema on initial chest X-ray. The POCUS and TTE show the VSD, and it excludes, very importantly, other structural abnormalities which we need to know about to treat the patient properly: acute MR, free wall rupture, or other post-MI complications. It also excludes, in this case, significant chronic or pre-existing disease which may alter immediate care, such as critical aortic stenosis, which can, of course, coexist with coronary disease. In this case, the TE and the CT didn't add any additional information, but confirmed the VSD and the other transthoracic findings. And then finally, the form of imaging that we haven't discussed yet, the coronary angiography and left ventricular autography, which is coming, are imaging, and these confirm the findings and enable therapeutic procedures. Next slide. So what questions in this patient at what stage of his workup can imaging answer that will change outcomes? Our thinking about the patient, concomitant disease compensation, and our treatment, such as emerging cath for probable PCI and VSD closure. What are the cons? Obviously the costs. The risks are the risks of the test. And there's the risk to imaging staff of exposure to COVID. But I think the most important con of additional imaging in this patient is delay of definitive treatment, possibly associated with further loss of myocardium, cardiac decompensation for continued volume load and pulmonary hypertension with congestion, worsening acute kidney injury, and so on. Basically, he could go down, have a downwards clinical spiral. Next slide. So the best imaging strategy for this patient is the best test, the right test for the right patient at the right time, done in the right way, of course. POCUS is quick and it's easy, but only if there is good expertise. A mixed diagnosis on poor images can be fatal. The transthoracic is diagnostic and provides all the information needed to exclude other pathology and immediately perform the rarely more than a short wait. Angiography and ventriculography are imaging required for definitive therapy, and other images bring longer delays, higher risks, and little additional information. Next slide, thank you.
Thank you so much, Dr. Douglas.
¿Un comentario, residentes? Creo que va quedando así muy claro, ¿no? O sea,
Sí.
¿Tú, Ricardo?
En el paciente, bueno, creo que no nos queda duda que el estudio ya se comentaron las respuestas, pero decía, en este paciente en específico, por ejemplo, hablando de la tomografía, si hubiera llegado el paciente con menos síntomas, un electro no tan claro como el que llegó ahí, sin el soplo, no más con el dolor torácico, entonces ahí la tomografía probablemente sí es una herramienta que de inicio nos puede dar mucha información para descartar varios diagnósticos que funcionan ahí. Incluso para ver la función ventricular, si hacemos...
Sí tienes abierto el... es que estás hablando otra vez de este. Okay.
Sí, si hacemos un estudio retrospectivo, por ejemplo, en el protocolo de adquisición de tomografía. Por poner un ejemplo, entonces el paciente mismo nos va, pues es el que nos va a decir qué posibilidades tenemos para hacer tratando de llegar al diagnóstico. Obviamente, cuando todo está disponible.
Claro. ¿Sí escucharon todos lo que dijo Ricardo?
Sí, doctor. Sí, claro. Sí. Sí, de acuerdo.
Sí, creo que lo dijo el doctor Mario García. Ese doctor lo conozco razonablemente bien. Que si bien su método, el que él promueve, es un muy buen método y que es útil para la mayoría de los pacientes que llegan a una sala, a un área de urgencias con un electrocardiograma normal, con dolor torácico, pues no era el momento para hacérselo a este paciente, ¿no? Hasta ahorita donde vamos, no he llevado el tiempo en que han estado presentando. O sea, ¿cuánto tiempo después de que llegó el paciente? Parece que, porque todavía le hicieron el eco transesofágico y el eco, la tomografía. Entonces, yo creo que nos van a presentar la angiografía que se ha de haber hecho, como decía el doctor García, ¿no? Salió un ecocardiograma pronto, rápido en el camino rumbo a la coronariografía, ¿no? ¿Verdad? Bueno, muy bien.
Sí.
¿Algo que quieran comentar?
Pues la importancia de optimizar los tiempos, ¿no? O sea, al menos algo que ya vemos claro, la gran importancia del eco de manera temprana en los pacientes, obviamente con este escenario clínico y la pronta, el evitar el retraso para llevarlo a un cateterismo cardíaco, teniendo en cuenta, como mencionaba en el contexto Ricardo, también este tipo de pacientes que a lo mejor no llegan que pueden llegar menos sintomáticos, con un electrocardiograma no tan específico, la otra batería de
Next we have Dr. Mahadavan, who will
Perdón, Miguelito, no. Perdón. Síguele.
Sí, pues nada más eso, agregar que si es el contexto de un paciente que podemos abordar de manera más detenida con estudios suplementarios, pues bueno, tener en cuenta la demás batería de estudios, pero en un paciente en agudo, la pronta realización del eco y el llevarlo a una intervención coronaria percutánea.
Sí, muy bien. Creo que lo puso esta doctora que tenía todo oscuro ahí atrás. En estos pacientes, acuérdense, el choque cardiogénico, como lo vimos, como lo vimos en la clase pasada, entre más nos tardemos en hacer cosas, entre más tratemos de estabilizar al paciente, etcétera, más mal nos le va a ir al paciente, ¿no? Si este paciente, yo creo que lo que hicieron probablemente es que fueron a la coronariografía, lo vamos a seguir viendo el jueves. Fueron a la coronario, yo creo que vieron que probablemente fuera trivascular o que hayan arreglado algo ahí en ese contexto para después llevarlo a cirugía. Dependiendo ahí, siempre es estar viendo constantemente al paciente cómo va, ¿verdad? Pero probablemente con los americanos los tiempos de cirugía no lo llevas ahorita, lo llevas dentro de 12 horas, dentro de 24 horas a repararle el septum, ¿verdad? Y hacerle revascularización coronaria, a menos que tuviera todas las condiciones y como que para intentar un intervencionismo. Pero bueno, ya lo seguiremos en el episodio 2 de este caso. Bueno, ok. Está bien, ¿no? Está padre.
Sí, está bastante bien.
Bueno, perfecto, jóvenes. Entonces mañana a las 7 clase, Miguel.
Sí, sí, al ratito se los mando.
Bueno, ok. Acuérdate que el doctor Leiva ahí está acompañándonos, entonces para ponerle más punch. Y
Muy bien.
y no, nada más eso. ¿Ok?
Ok,
Pues
muy bien.
el jueves seguimos con esto, terminamos esto y a lo mejor alcanzamos a ver una de las pláticas así de la utilidad del eco de contraste en los pacientes que empezaron a tener ahí en Stony Brook, en Nueva York, con COVID.
Ok.
Ok, sí, doctor.
Sale, chavos. Bye.
Gracias.
Gracias.